One of the therapies we offer for patients with both metastatic and primary cancers to the liver is a treatment called SIRSFIRS, which is a form of selective internal radiation therapy. What that means is that these are radioactive microbeads that are injected directly into the liver, which are done in close association with our interventional radiology colleagues, Dr. Maeslein, Dr. Patel, Dr. Haskell, among others. What we try to do with this is to get patients radiation delivery as close as possible to the tumors, and we do this by injecting it directly into the hepatic artery, which is a blood vessel that tends to feed tumors more than the normal liver, which gets most of its blood from a different blood vessel called the portal vein. SIRSFIRS are just one amongst several different liver-directed therapy options we have, which we almost always discuss in our liver-directed therapy tumor board. And we try to make sure that the best option is given to the patient. We also have other options in our department, as well as other options in interventional radiology and surgical oncology, including stereotactic body radiotherapy, radiofrequency ablation, but SIRSFIRS has emerged as a very strong aspect of our liver-directed therapy program. The liver is one of the big processors of the body, and therefore all blood, especially from the gut, flows through the liver, as does blood from other parts of the body too. This is one of the reasons that SIRT was initially used for colorectal cancer, because one of the sites that colorectal cancer is drained to is the liver. And we often find that even with chemotherapy and other therapies given to the patient, the disease is well controlled in other parts of the body, but not as much in the liver. And it's these patients that are the best candidates for SIRT therapy, which is the SIRSFIRS treatment that we give them. The best part about SIRSFIRS therapy is it is an outpatient procedure and usually does not require an overnight stay at the University of Maryland. It is a procedure which usually consists of three parts. One is the consultation with both the radiation oncologist as well as the interventional radiologist. The second part of it is actually a scan that allows us to determine if the patient is a good candidate for SIRT therapy. And the third part is the actual procedure itself, which usually can be spread over 1 or 2 days, about 3 to 4 weeks apart. In all instances, the patient does not have to stay here overnight. They get to leave usually on the same day and go home. And usually the side effects are tolerated pretty well and only last about a week or so. We have found that patients that get SIRSFIRS early on in the treatment tend to do better, and patients that have not had disease grow too much, or patients that have not had many different cycles of treatment before they come to us for therapy. And therefore we always recommend that patients talk to us early on in the treatment cycle regarding the use of SIRSFIRS. There have been different studies, and there is actually an international trial right now that is looking at the aspect of using SIRSFIRS early on in therapy as opposed to later on in therapy, because there's some promising data that says that they help better when they're early on in treatment.